Uh, I am Young in Ewha Women's University Seoul Hospital. The topic I am going to talk about is correlative imaging in lung cancer. As I know, there was a lecture on the same topic in the TEIN lecture series of the last year by Professor Hyungjun Im. And this lecture slide is made based on the contents of the last year lecture with only minor revision. I'd like to thank Professor Im for providing the materials. More specifically, we will summarize the basic knowledge such as normal anatomy and structure of the thorax and TEIN staging, as focusing on the evaluation of lung cancer based on CT and FDG PET-CT. Today's topic is not about something new, but a set of basic and core things that nuclear medicine physicians must know. I believe you already know most of what we are going to cover today, but I hope this session will be helpful to you by revisiting and summarizing them. The lecture consists of two parts. In the first half, we are going to review the key points of normal anatomy of the thorax, focusing on the information that could be helpful in lung cancer evaluation. In the second half, we are going to briefly talk about the clinical use of FDG PET-CT in lung cancer and FDG PET-based staging of lung cancer with several typical cases for practice. Let's begin the first half. As you all know, there are two lungs in the human thorax. The right lung is divided into three lobes, upper lobe, middle lobe, and lower lobe. And the left lung is divided into two lobes, upper and lower lobes. The trachea, which serves as the main pipe for supplying and expelling air, is centered in the thorax. The trachea is divided into the right main bronchus and the left main bronchus at the point of carina, and then into each lower bronchus responsible for each lobe. Let's take a closer look at the airway. As I just mentioned, the trachea is the highest level of the airway with the largest diameter. The trachea is then divided to the main bronchus for each lung, then lower bronchi, segmental bronchi, and subsegmental bronchi. After several steps of division, the airway comes to bronchioles. Bronchiole differs from bronchus in that it does not have a cartilage surrounding it. After multiple steps of division also, bronchioles reach the terminal bronchioles and then respiratory bronchioles, which are structures just before the alveoli where air change occurs. The gradual division of the airway can be described as generations. The trachea, which is in the highest level of the airway, can be called generation 0. Then main bronchi can be called generation 1, lower bronchi are 2, and segmental bronchi are 3. Usually after 7th generation, airway becomes the bronchiole, which does not have cartilages, and reaches alveolar ducts at about 20th generations. The sum of total cross-section area of the airway increase exponentially along the division, and the airway of respiratory zone can have a cross-section area large enough for air exchange. Although the airway has multiple levels of structure, as described before, the structures that can be grossly distinguished in CT or PET-CT images are only the upper few levels from the trachea to subsegmental bronchus. Therefore, we only need to know about the lobe of each lung and the segment that composes it. Right upper lobe is divided into apical, posterior, anterior segments, middle lobe into lateral and medial segments, lower lobe into superior, medial basal, anterior basal, lateral basal, and posterior basal segments. Left upper lobe is divided into apical, posterior, anterior segments and lingual division, which consists of superior and inferior segments. And left lower lobe is divided into superior, anterior medial, lateral basal, and posterior basal segments. So let me briefly explain the functional unit of the respiratory zone. The alveolus is the smallest gas exchanging unit of the lung. Primary pulmonary lobule is defined as the lung unit distal to the respiratory bronchioles. It is composed of alveolar ducts, alveolar sacs, and alveoli. The combination of primary pulmonary lobule and respiratory bronchiole is called acinus. Secondary pulmonary lobules represent a cluster of 30 to 50 acini supplied by a common distal pulmonary artery and bronchiole. These clustered acini are bounded by interstitial fibrous septa, known as interlobular septa, which outline an irregular polyhedron of varying size between 1 and 2.5 centimeters. In the core of lobules, a branch of terminal bronchioles and pulmonary arterioles are present. In the periphery of lobules, which are also called as interlobular septa, pulmonary veins and lymphatic vessels are present. Let's take a closer look at the secondary pulmonary lobule. Secondary pulmonary lobule is composed of 30 to 50 primary pulmonary lobules. Secondary pulmonary lobule is supplied blood by a lobular artery and air by a lobular bronchiole, which is located in the center of the lobule. Lobular bronchiole and lobular artery are divided into multiple branches called acinar artery and respiratory bronchiole, which cover primary pulmonary lobules. Secondary pulmonary lobules are separated from each other by interlobular septa, which are composed of connective tissues, pulmonary veins, and lymphatic vessels. And let me move on to the next part of the normal anatomy, mediastinal lymph node map. This section is the most important part of the first half, I think. Lymph node staging is one of the most critical parts for staging of lung cancer patients who consider to undergo surgery. Lymph node staging of lung cancer depends on the location of metastatic lymph nodes, not on the number of metastatic lymph nodes. So accurate classification of lymph nodes according to the location is essential for accurate lymph node staging. As you know, mediastinal lymph node map developed by IASLC is used usually, and I'd like to review this, focusing on important points that can cause the change of stage and therapeutic strategies. IASLC classified mediastinal lymph nodes into 14 stations based on anatomical location. Let's take a look at them one by one. Station 1 includes low cervical, supraclavicular, and sternal notch lymph nodes. Station 1 is the only station outside the mediastinum and lungs, and station 1 nodes are classified as N3 nodes, no matter if it's lateral or contralateral. So it is important to have a clear definition of station 1. I'll go into a little more detail on this after I introduce station 2 and 3. Station 2 includes upper paratracheal nodes. As the name suggests, it refers to those located around the upper trachea, and it is divided into 2R of the right side and 2L of the left side. The border between 2R and 2L should be kept in mind because if the lateral station 2 is an N2, but contralateral station 2 is N3, the border is the left lateral border of the trachea as described in this third figure, this vertical line. So we should keep in mind this vertical line as a border between 2R and 2L lymph nodes. For the next, the station 3A refers to prevascular nodes, and station 3P refers to retrotracheal nodes. A means anterior, P means posterior. 3A nodes are located between the sternum and both lungs and major vessels. 3P nodes are located between the trachea and vertebra. The lower border of 3P station, the inferior border of 3P station is the carina, because the carina is the end of the trachea, and the 3P means the retrotracheal lymph node station. So the lower border is the carina. As I mentioned before, the differentiation between station 1 and station 2 or 3 is very important because if the lateral station 2 or 3 is N2, but if the lateral station 1 is N3, the core concept is that station 1 is outside the thoracic cage and station 2 and 3 are inside the thoracic cage. First figure shows the thoracic inlet, a definitive anatomic boundary that exists between the neck and superior mediastinum. The anatomic landmarks of the thoracic inlet are the superior margin of the manubrium, the superior margins of the first ribs, and the T1 costovertebral junctions. In the sagittal section of the figure 2, the first rib and the lung apex can be the landmark of the boundary between station 1 and 2 or 3. As you can see, thoracic inlet has an oblique plane superior posterior to inferior anterior. So in the transaxial section of the figure 3, station 1 is located at the anterior side of the first ribs or anterior border of the lung apex, because anterior side is the outside of the thoracic cage and posterior side is the inside of the thoracic inlet. And so the station 2 is at the posterior side of the first ribs or anterior border of lung apex. Now going back to the IAS LC map, the superior margin of the station 2, 3A, and 3P is defined as the top of the lungs. Thoracic inlet has an oblique plane and the lung apex level is more superior at the posterior side. So the station 3P appears earlier at the higher level and station 2 for the next, and station 3A comes last. The boundary between station 1 and station 2 is the imaginary horizontal lines drawn on the anterior border of the lungs. From the superior border of manubrium, which is the lowest level of the thoracic inlet, station 3A appears and station 1 is not present anymore. Station 4 refers to lower paratracheal nodes. They are located around the lower trachea and divided into 4R and 4L by the left lateral margin of trachea, like in stage 2. The differentiation between station 2 and station 4 is not essential for staging, but should be kept in mind for accurate and consistent reporting. The boundary between 2R and 4R is the intersection of inferior margin innominate vein. So an innominate vein inferior margin with trachea. So this level. And the boundary between 2L and 4L is the superior margin of aortic arch. So this level. So you should keep in mind this order to report the FDG PET in lung cancer staging patients accurately and consistently. Station 5 refers to aortic pulmonary window nodes. Station 5 starts at the level of lower border of aortic arch and ends at the left main pulmonary artery. The boundary between 4L and 5 is ligamentum arteriosum, but this structure is difficult to visualize in CT. So the major border, the border between 4N and 4L and 5 is defined as the an imaginary line drawn on the most posterior part of the ascending aorta to the most anterior part of the descending aorta. This imaginary line. Station 6 para-aortic nodes are located at anterior and lateral aspect of aortic arch. The station starts at the level of superior border of aortic arch and ends at the level of inferior border of aortic arch with aortic arch, where it meets station 5. The boundary between station 6 and 3A is an imaginary horizontal line extending from anterior wall of the arch of the aorta. Station 7's carinal nodes includes nodes located just below the carina. And station 8 refers to paraesophageal nodes below the carinal level. It meets the station 7 at the level of lower border of right bronchus intermedius, this point, and upper border of the left lower bronchus, this point. This boundary between station 7 and 8 might matter because station 7 always belongs to N2 nodes, but station 8 can be N2 or N3 according to the laterality. If lateral station 8 is N2 and contralateral station 8 is N3. And station 8 continues inferiorly to the diaphragm, which is the lower end of the thorax. Station 9 refers to pulmonary ligament nodes. The pulmonary ligament is the downward extension of the pleural slit that surrounds the hilum. The station 9 is not frequently involved station. Then station 10 and 11 belong to hilar lymph nodes in a broad sense. Station 10 includes lymph nodes around the main bronchus, and station 11 includes nodes around the lower bronchus and bronchus intermedius. Differentiation between 10 and 11 is not critical for staging. However, confusion between 10 and 11 is quite often, and the definition should be clear. The most common mistake occurs regarding the space between right upper lobe bronchus and right bronchus intermedius. This point, because the right upper lower bronchus already branched out. So nodes in this space should be called 11R, not 10R. The boundary between station 4 and station 10 is more important. It can be ambiguous at the level of carina, but it is very critical in staging because if letter station 10 belongs to N1, but if letter station 4 belongs to N2. At the right side, the boundary between 4R and 10R is the arch of azygospain, this structure. And at the left side, the boundary between 4L and 10L is the superior margin of left main pulmonary artery. Now we can define the location of lymph nodes by the IASLC classification, but there are some ambiguities regarding the laterality of nodes. The boundary between right and left paratracheal nodes are defined well in IASLC map, but with regard to the sightedness of other mediastinal lymph nodes, such as 3A, 3P, and 8 station, the IASLC lymph node map does not provide a boundary to distinguish between right and left side lymph nodes. In radiographics, there are some practical suggestions about that. They suggest that station 3A should be divided by the midline of the trachea, and station 8 should be divided by the midline of the esophagus. And station 5 and 6 are definitely left-sided, and N2 for left lung cancer and N3 for right lung cancer. Station 3P usually belongs to right side lymph nodes because they are located at the posterior side of the trachea, and the center of nodes will be the right side of the left lateral tracheal wall, which was used as the border between 2R and 4R, 2R and 2L, or 4R and 4L. So 3P usually is regarded as a right side lymph node station, but it can be defined case by case. Now let me move on to the next part. In this part, we are going to review the clinical use of FDH-PET-CT in lung cancer over TNM staging of lung cancer and practice applying it to real clinical cases. FDH-PET-CT is now broadly used in diverse clinical contexts of lung cancer. The NCCN guidelines provide somewhat conservative recommendations regarding clinical use of FDG-PET in lung cancer. We can strongly recommend FDG-PET-CT in several indications as follows. Characterization of an indeterminate solid nodule larger than 8 millimeter or partially nodule with 6 millimeter or larger solid components. Initial staging in patients with stage 1 to 4 non-small cell lung cancer. When recurrence is suspected or confirmed, or after treatment for local regional recurrence, and delineation of gross tumor volume in patients who are planned to receive radiation therapy. But FDG-PET-CT is usually not warranted in the routine surveillance during NED status without the evidence of disease. The guidelines are just generalized guidelines, not the law, and we can use FDG-PET in other clinical indications such as therapeutic response evaluation or surveillance in specific situation, case by case. FDG-PET-CT can be applied for the evaluation of solitary pulmonary nodule before the confirmation of malignancy. Nodules can be classified into 3 categories based on gross CT findings: solid nodule, pure ground glass nodule GGN, and partially nodule PSN. Among them, partially lesions have the highest malignancy rate of 63%. Reported, which warrants more aggressive evaluation. For incidental solid nodules and chest CT, NCCN guidelines recommend to consider FDG-PET-CT for nodules of diameter greater than 8 millimeters. On the other hand, for partially nodules, incidentally found in chest CT, considering FDG-PET-CT is recommended when solid component is larger than 6 millimeter diameter. FDG-PET-CT is highly recommended in the staging of newly diagnosed lung cancer. The recommendation is consistent regardless of the disease stage determined before PET imaging. Even in the early stage, stage 1A lung cancer, FDG-PET-CT is recommended for staging. In the setting of surveillance after completion of definitive therapy, routine follow with FDG-PET-CT is not indicated. However, when the recurrence is diagnosed or suspected, FDG-PET-CT is highly recommended. FDG-PET-CT is also recommended after the therapy for local regional recurrence to exclude the development of disseminated disease after the diagnosis of recurrence and during the therapy for recurrence. Regarding the staging, as you all know, lung cancer staging is usually based on AJCC 8th edition TNM staging. There were several major changes in T staging at 8th edition AJCC in comparison with 7th edition. TIS and T1A MI were newly categorized. And T1 stage was further stratified according to tumor diameter. And criteria for T2B and T3 have been lowered. And proximal main bronchus involvement and atelectasis were downstaged, and diaphragmatic invasion was upstaged. Let's review TNM staging respectively in detail. Stage T1 includes tumors with the longest diameter shorter than or equal to 3 centimeters. Stage T2 includes tumors between 3 centimeter and 5 centimeter, and tumors that involve the main bronchus or cause atelectasis extending to hilum regardless of tumor size. Stage T3 includes tumors between 5 centimeter and 7 centimeter, or tumors invading parietal pericardium, chest wall, or pharynx. Metastasis to the same lobe of the lung is also classified into T3. Stage T4 includes tumors larger than 7 centimeter, and tumors invading carina, trachea, diaphragm, red vessels, and other organs. Metastasis to each latter different lobes is classified into T4. In N staging, N1 includes only ipsilateral hilar lymph nodes. The carina and ipsilateral mediastinal nodes are classified into N2, and contralateral mediastinal hilar and supraclavicular nodes are all N3 nodes. And M1 is classified into 3 subcategories. M1A includes metastasis to contralateral lung, malignant pleural or pericardial effusion or seeding nodules. M1B refers to single extrathoracic metastasis, and M1C means multiple extrathoracic metastasis, more than one. Overall stage can be categorized according to T, N, and M stage as described here, but we don't have to memorize this at all. There are a few main points we should keep in mind when reading FDG-PET-CT for T staging of lung cancer. Tumor diameter is the most important parameter, of course. In addition, when tumors are located centrally, bronchial involvement should be evaluated. Tumors are T2 when the main bronchi are involved, and T4 when the carina or trachea are involved. Tumor direct invasion to adjacent structures should be checked. Tumors are classified to T2 for invasion of visceral pleura, T3 for chest wall and parietal pericardium, T4 for diaphragm, red vessels, and other organs such as esophagus, heart, and vertebra. When separate tumor nodules are detected, nodules of same lobe are regarded as T3 lesions. Different lobes of ipsilateral lung as T4 and contralateral lung as M1A. Atelectasis or obstructive pneumonitis extending to the lung hilum is regarded as T2 finding. And staging is so simple. Based on FDG uptake and CT findings of lymph nodes, past medical history, and underlying inflammatory conditions of patients, positivity of observed lymph nodes should be determined and reported with accurate anatomical classification based on IASLC map. Regarding the performance in end staging of lung cancer, FDG-PET is well known to have a higher accuracy in comparison with contrasting and sensitivity. Sensitivity varies from 58% to 94%, and specificity from 76% to 96% for the detection of mediastinal lymph node metastasis. Negative predictive value is so high, values 94% in T1 disease and 89% in T2 disease. In end staging of lung cancer, FDG-PET is well accepted as the modality of choice for evaluation of distant metastasis, except for brain metastasis. By a meta-analysis, patient-level sensitivity and specificity for distant metastasis diagnosis are reported to be 93% and 96%. Glucose metabolism of lung cancer measured as FDG uptake, known as standardized uptake value SUV, is known to be a significant prognostic factor in lung cancer patients. The prognostic significance for predicting overall or event-free survival in lung cancer patients has been repeatedly reported by a number of clinical studies. In addition, as you know well, the volumetric parameters such as metabolic tumor volume and the total lesion glycolysis, which is the production of metabolic tumor volume and average SUV, have been reported as significant prognostic markers by several previous studies. As well as the above-mentioned conventional parameters, diverse texture features extracted from FDG-PET data have been investigated. And the advances in data analysis technology enable the effective and systematic analysis of this kind of large amount of information extracted from a number of features of FDG-PET from multiple cancer patients and promoted the development of radiomics field. Further validation is warranted for the future clinical use of FDG-PET findings and this kind of radiomics or the other data analysis field as an important prognostic factors. Now, let's take a look at typical cases for practicing FDG-PET reading in lung cancer patients. The first case is about 69-year-old female patient who underwent FDG-PET for initial evaluation for a solitary pulmonary nodule. These are FDG-PET images of this patient. And what do you think the stage is? On 1.5 centimeter size nodule with minimal FDG uptake is observed in the left upper lobe without any possible metastatic lesions. So what's the stage? As you all know well, the tumor size is between 1 and 2 centimeter, and no adjacent structure invasion or bronchial involvement is observed. So the stage is T1B and N0, M0. So the patient received lobectomy, and final pathologic stage was also T1B and 0. The next second case is about 67-year-old male patient who underwent FDG PET-CT for staging of suspected lung cancer. These are the FDG PET-CT images of the patient. 3.5 centimeter size hypermetabolic mass is observed in the right upper lobe. And what's the stage? What do you think? The right carotid lesion is considered to be primary carotid tumor, such as Warthin's tumor. And no other possible metastatic lesions are observed. Tumor size is between 3 and 4 centimeter. No invasion or bronchial involvement were observed. No other metastatic lesions, including lymph node or liver or bone, were observed. So stages T2A and 0 M0. So the patient received lobectomy, and final pathologic stage was also T2A and 0. Third case is about 65-year-old female patient who underwent FDG PET-CT for staging of suspected lung cancer. These are the images of FDG PET-CT performed for the patient. And what's the stage? Tumor diameter is about 2 centimeters. And is the stage a T1B. However, as you can see in the third figure, the fissure retraction is observed around the tumor, suggesting pleural involvement, which can result in upstaging of T stage to T2, regardless of tumor size. And no metastatic lesions are observed. So the stage is T2A and 0 and 0. The patient received lobectomy, and pathologic stage was also T2A and 0. And visceral pleural involvement was confirmed by pathologic diagnosis. Next, first case is about 65-year-old male patient who underwent FDG-PET-CT for staging of suspected lung cancer. These are FDG-PET-CT images. And what's the stage? Primary tumor is 3.5 centimeter size, hypermetabolic mass in the right upper apex without invasion to adjacent structures. Hypermetabolic lymph nodes are observed in station 11R, 10R, and even in 4R. This lymph node is classified as 4R because the center of lesion is above the arch of a zygous vein, even though it seems somewhat ambiguous in this image. So the metastatic nodes are observed in ipsilateral mediastinum, and the stage is suspected as T2A N2 M0. EBUS-guided biopsy for 4R lymph nodes was performed, and pathologic diagnosis was metastatic adenocarcinoma. So the patients are planned to receive neoadjuvant CCRT and following definitive operation. Fifth case is about 66-year-old male patient who underwent FDG-PET-CT for staging of suspected lung cancer. These are FDG-PET-CT images. And what's the stage? Primary tumor was 1.8 centimeter size, hypermetabolic nodule, located in the right upper posterior segment. And in this case also, hypermetabolic lymph nodes are observed. In station 2R or 4R, it's somewhat ambiguous because the innominate vein is visualized in this section. And also in station 1R in the third figure. Supraclavicular lymph node metastasis is suspected, and stage is T1B and 3M0. So percutaneous biopsy for 1R lymph nodes pathologically confirmed metastatic adenocarcinoma. So CCRT was planned for this patient. The next sixth case is about 60-year-old male patient who underwent FDG-PET-CT for lung cancer staging. These are FDG-PET-CT images for lung cancer staging, and what's the stage? Radioactivity outside the body of the right side of abdomen is a contamination. It's radioactive contamination. For primary tumor, hypermetabolic mass is observed in the left lower lobe. And hypermetabolic enlarged lymph nodes is observed is in station 8, the left side, suggesting and 2 metastatic lymph node. And in addition, separate tumor nodules are suspected in the same lobe, left lower lobe of the lung, and also in contralateral lung, right lung. So the stage is T3 for separate tumor nodule of the same lobe, and then 2 for its lateral mediastinal node, and M1A for the contralateral lung nodule. Ibus-guided biopsy of the station 8 node diagnosed metastatic squamous cell carcinoma. So the palliative chemotherapy was planned for this patient. Second case is about 85-year-old male patient who underwent FDH-Pacific lung cancer staging. These are the FDH-Pacific imagings for this patient. The primary tumor is relatively small size, hypermetabolic nodule located in right upper lobe. However, multiple hypermetabolic lymph nodes are observed in 1R, 2R, 3A, 4R, and also in 7. In addition, moderate amount of pleural effusion and diffuse hypermetabolic lesions along the pleura and fissures are observed in the right hemithorax, suggesting malignant pleural effusion and pleural seeding. So stage A is T1, but N3 and M1A for pleural seeding, malignant pleural effusion. Pleural effusion cytology of this patient diagnosed adenocarcinoma, and palliative chemotherapy was planned for this patient. The last case is about 72-year-old male patient who underwent FDH-Pacific for lung cancer stage. There are FDH-Pacific images and what's the stage. There are multiple lesions, but the stage is very simple. For the primary tumor, a large hypermetabolic mass is observed in the left upper lobe, suggesting T4 cancer. And hypermetabolic lymph nodes are observed in the left lung hilum and station 5, suggesting N2 because of its lateral mediastinal node metastasis. And hypermetabolic osteolytic or bone disrupting lesions are observed in left parietal bone, right 10 and 11th ribs, suggesting multiple bone metastasis. In addition, hypermetabolic nodules are observed in the left adrenal gland and the left kidney lower pole, also suggesting metastasis. The frequently involved distant metastatic location from non-small cell lung cancer includes contralateral lung, liver, brain, adrenal gland, bones and kidneys. So we should check up these organs when reading the FDG-PET images of patients with relatively advanced T or N stage of lung cancer. So the stage for this patient is T4 N2 and M1C, or multiple extrathoracic metastasis. Percutaneous biopsy for lung was performed, and the pathological diagnosis confirms squamous cell carcinoma, and palliative chemotherapy and radiotherapy for the right side ribs are planned for this patient. So let me wrap it up. I'd like to say that you should keep in mind the IASLC lymph node map focusing on differential points, which can change the stage of patients, such as a boundary between station 1 and station 2 or 3, station 4 and station 10, and right side and left side of each lymph node station. And as a nuclear medicine physician, we should be able to recommend FDG-PET-CT in lung cancer patients in appropriate clinical indications. So we should know about that. And finally, we should be able to accurately diagnose the lung cancer patients who underwent FDG-PET-CT for staging, and we should determine the accurate TNM staging for clinician to determine what risk treatment to perform. And that's all for my presentation, and thank you for your time and listening. And if you have any comments or questions, please let me know. Do you have any comments or questions? If you have any questions or comments after closing this session, just let me know through the professor.
Hello, I'm Bayu. I'm from Indonesia. I want to ask how to differentiate the metastasis and the lung tuberculosis. Thank you.
Hello, you You're asking about the differentiation between malignancy and lung tuberculosis. That's very difficult and ambiguous points.
Yes.
There as are, as I know, there are no absolute criteria for differentiation between tuberculosis and lung cancer. So we should take a very comprehensive and closer look at the patient history and a lot of possible information we can get from the medical history and CT findings, and then we should just determine. And the answer may be correct or sometimes incorrect, but I think the differentiation between these two pathologies is might be impossible with the FDG PET-CT. So as I hope the new tracers such as FAP can somewhat differentiate between these kinds of false positivities, but I think capacity finally cannot differentiate between lung tuberculosis and lung cancer. So in clinical practice, so the decision to perform surgery or just watch and wait or medication should be made based on many components of clinical settings and patient-based factors. I'm so sorry for this kind of answer. In addition, some kind of typical CT findings can be helpful, as you know, kind of a typical classification or lymph node, classified lymph nodes or and some.
Thank you.
Yeah. But FDG uptake cannot differentiate between these kind of pathologies.
Thank you, Dokter.
Do you have any other questions or comments? Then let me close these sessions. Thank you for listening for everyone and see you next time. Thank you.